Hey guys, welcome back to Harrison Learns, where we crack open Harrison principle like it's your favorite cheat sheet. Today we are diving into Leishmaniasis, the forgotten tropical terror caused by Leishmania species that itch right on sandflies and wreak havoc on your reticuloendothelial system. Why care? This protozoan nightmare affects over 1 billion people in 99 countries. It is a top 10 neglected tropical disease per WHO, eating kids under 5 and men hardest, especially in places like India and Brazil. We'll break it down etiology and life cycle first, then visceral, cutaneous, and mucosal forms. Let's jump in. Alright, etiology. Leishmania belongs to the family Trypanosomatidae. Yeah, cousins to those trypanosomes that cause sleeping sickness. The organisms are transmitted by phlebotomine sandflies of genus Phlebotomus in Old World, like in Asia, Africa, and Europe, and genus Lutzomia in New World, like America. Life cycle. It is a digenetic dance between sandfly and mammal host. Basically, it can be zoonotic, means it has reservoirs like dogs or rodents, or it can be anthroponotic, means human to human. Here is the cycle. First, infected sandfly takes a blood meal from you, injects promastigotes, which are motile flagellated forms, via proboscis. Your macrophages phagocytoise them like overeager bouncers. Then inside, promastigotes transform into amastigotes, which are non-motile round intracellular forms, and then they multiply in macrophages by binary fusion, and they burst cells and spreading the party. Back to the fly, it bites another host, sucks up amastigote-laden macrophages. Then in the fly's midgut, amastigotes morph back into promastigotes, migrate to proboscis, and wait for the next meal. Harrison called this reticuloendothelial roulette because it loves spleen, liver, and your bone marrow. And one more thing I want to add is, it is categorized into three forms. One is visceral leishmaniasis, another one is cutaneous leishmaniasis, another one is mucosal leishmaniasis. First is visceral leishmaniasis, which is also known as kala-azar or black fever in Hindi, which is caused by L. donovani complex, which includes L. donovani and L. infantum, whereas L. chagazi in New World. Predominantly, it's reticuloendothelial organs like spleen, liver, bone marrow, and your lymph nodes. What are the clinical features? It starts insidious 2 to 8 months post bite. Most common is moderate to high grade fever with rigor and chills. And it has double quotidian spikes like malaria's evil twin. In week 2 of illness, you can see splenomegaly, which is very massive and most commonly affected organ is spleen. And you can see hepatomegaly in 80% cases. You can see lymphadenopathy, and it is more common in African kids. And then the classic features: weight loss, hypopigmentation, the kala greyish skin, which is characteristic feature of visceral leishmaniasis. Then you can see anemia. Then you can see pancytopenia from hypersplenism and marrow infiltration. Pancytopenia is pathognomic, which means low everything screams VL in endemic areas. Treatment. First line preferred drug is pentavalent antimonial, means sodium stibogluconate or meglumine antimoniate. And second line choice, or for relapses or HIV associated leishmaniasis, you have to give amphotericin B, liposomal amphotericin B. Remember, for pentavalent antimonial, watch for cardiotoxicity. And others are paromomycin or miltefosine. Miltefosine, remember here, it should be not given in pregnant patients. Post kala-azar dermal leishmaniasis. It occurs in 2 to 50% of patients develop skin lesions concurrent with or after cure of visceral leishmaniasis. Most common, you can see hypopigmented macules, papules, or nodules, or diffuse infiltration of skin and oral mucosa. Treat like VL to stop transmission reservoirs. Shifting to most common form of leishmaniasis, which is cutaneous leishmaniasis. It occurs in 90% of cases. it localized skin showdown. In old world, it is caused by Leishmania tropica, which is confined to urban or suburban areas, and it is anthroponotic. And it is also caused by Leishmania major, which is zoonotic cutaneous leishmaniasis. And in New World cutaneous leishmaniasis, it is caused by L. mexicana, L. panamensis, L. amazonesis, which are mainly zoonotic. Clinical features. It starts as painless papule at bite site after weeks of post exposure and then swells to nodules and then ulcerates. The base of ulcer is painless and consists of necrotic tissue and crusted serum, which is a volcanosine in some. Satellite lesions are common, but they heal spontaneously within 2 to 15 months, leaving atrophic scars. No systemic fever unless secondary infection. And remember, old world ulcers are on face or extremities more commonly, and new world on legs are more aggressive. Diagnosis. Gimso on dermal scrapings. It is gold standard. You can see amastigotes like safety pins. Biopsy for culture or PCR if tricky. Don't biopsy the ulcer edge. Scrape it. Treatment. It is always self-limiting, but treat to speed healing or prevent scars. First line, it is always pentavalent antimonial, that is sodium stibogluconate, local or intralesional SSG for simple cases. But whereas in systemic cases, you have to give SSG or miltefosine or fluconazole. And the treatment depends on species and country of acquisition. Next is last but destructive, mucosal leishmaniasis. It occurs in 5% of New World cases by subgenus Viania, and young men with chronic lesions of cutaneous leishmaniasis are particular risk. Lesions occur in or around the nose or mouth are typical presentation. And remember, parasite spreads via lymphatics of bloodstream to mucosal tissues of upper respiratory tract. And the clinical features are nasal stuffiness and bleeding, followed by destruction of nasal cartilage, perforation of nasal septum. Okay. And remember, there is no spontaneous healing over here. Diagnosis is by biopsy smears and culture from mucosa. And treatment, obviously pentavalent antimonial is drug of choice, which is SSG, sodium stibogluconate, and amphotericin B in relapse cases. Leishmaniasis, from sandfly sting to systemic sting. Recap: life cycle in macrophages, VL fetal without treatment, CL self heals but scars, ML mutilates. Comment on your opinion on this video. If this simplified Harrison for you, smash the like button and subscribe for weekly videos and share with a study buddy. Stay curious, med fam. See you soon.